Well, regarding clinical failure in community-acquired bacterial pneumonia, in terms of definitions, I mean, clinical failure is really the failure of the patient to respond in the predictable time frame that we normally would be accustomed to.
So a clinical failure could be extending the therapy, going to hospital, or seeing a specialist like an infectious disease to get another opinion based on why this patient hasn't achieved the goals that we set forth for that person.
For me, typically what we see is patients just not getting better. They'll call back after a week or two and say, I'm still not 100%. That's a situation where I think about changing the antibiotic or something else is going on.
There may be multiple reasons why a patient may not quickly respond, but I think one definition of failure is the lack of response to what you believe to be the appropriate antibiotic for that particular patient.
Resistance is definitely a cause of clinical failure. Resistance, like macrolide resistance in the community, is increasing. And talking about community-acquired pneumonia, the most common cause is strep pneumo, and macrolide resistance to strep pneumo is as high as 30 to 50%. So that can be a cause of clinical failure as well.
Once the patient is deteriorating, I think the alarms go off and realize that it may be that we have the wrong antibiotic, or it may be there's something else going on, and this is where we really require help or admit to the hospital.
So typically, one of the first steps is, aside from looking for complications, is to broaden antibiotic coverage, and so patients get exposed quite often to a variety of antibiotics.
Well, oftentimes some of the patients who come into our ICU come in with worsening respiratory status. Some of them require mechanical ventilation. And failure means these patients have been prior treated with antibiotics as an outpatient or even as an inpatient in regular floors. And for some reason, they come up to the ICU level of care has to be stepped up because their clinical course deteriorates.
I think it's important, whether they don't improve or certainly if they start deteriorating, that it's really important to reassess why this is happening. And typically we approach it as sort of the classic triad of the host bug and the path and the drug.
I think whether it's a primary care physician or emergency physician, we often don't see our own failures, our own clinical failures. We'll place them on an antibiotic. Say in the community setting, after a week the patient will come back and they're still not doing better. They may be prescribed another course of antibiotic if it's a mild to moderate disease, and the patient may get better, even if there's potential resistance. So it's harder to recognize resistance in the community than truly in a hospital setting.
Clinicians may not have the opportunity to follow up with their patients. And that patient may actually wind up in another clinician's office, so they may bounce from one office to another before they actually get response to therapy, or maybe they'll even be admitted to the hospital.
There's really a fractured nature in healthcare, from the primary care office to the ED to the hospital. And so, I would say, at least in our practice from a hospitalist standpoint, very rarely do you see a patient in the ER to admission to discharge. We're always working in shifts, and we're almost always not seeing that patient from one moment to the next. And so to judge clinical failure, you sort of have to see that sort of trend across time, I guess.
I think I think clinical failure in CAP is an important issue, because I think more and more this is a topic that is not well studied.
So it is an ongoing real challenge.